All right, so glad you guys could join us today. I know our team is fresh off of the VNPC Day of Learning we had Sunday and Monday, March 17th and 18th at the Westin in Richmond, Virginia. Definitely mark your calendars for October. We have our annual summit coming up October 20th and 21st in Charlottesville, Virginia. That's definitely not to miss, so go ahead and mark your calendars. We'll send out more information probably in April, May about that. And this webinar is going to be recorded, as all of ours are, and it will be on the VNPC YouTube channel within 48 hours. So you can tell your coworkers to catch it there if they weren't able to join us. And with that, I want to go ahead and introduce our guest, Kalie Owen. Kalie is the clinical social worker on the OB Motivate team at VCU Health in Richmond, Virginia. She has experience as a substance use counselor at a methadone clinic and developed a caseload that included pregnant and parenting women. Kalie also worked as a case manager for Richmond CASA, managing advocates for children in abuse and neglect cases. With a history as a birth doula, Kalie's specialty lies at the intersection of pregnancy and substance use disorders. So with that, I'll toss it over to Kalie.
Hi, thank you so much for having me today. I'm really excited to speak with you all. Let me go ahead and share my screen. All right, so you should be seeing my presentation now. Just jump in if you're not. So I am from VCU Health, and I'm going to talk to you a little bit today about our program at the OB Motivate Clinic and just general care for pregnant and postpartum patients with opiate use disorder. So this is our clinic. We are a perinatal addiction program. In order to refer, people can refer themselves or they can be referred by other professionals. They can call that phone number and ask to be scheduled with the OB Motivate team. Our physicians are Dr. Caitlin Martin and Dr. Catherine Tyson. They're both OBGYNs with specialty in addiction care. We have two locations where we see patients in Richmond, Virginia. We see them at the Jackson Center, which is the general outpatient addiction center for VCU. And then we also see them at the outpatient adult pavilion, the new AOP building at VCU. And that is where we see like our patients who need OBGYN care and who are pregnant and recently postpartum. So some goals today, just talking to you about our program with our harm reduction care model, talking about evidence-based medications that are safe to be prescribed to pregnant and breastfeeding parenting women with opiate use disorder, reviewing some social determinants of health that can impact a pregnant parenting woman's substance use disorder and also her access to treatment. We'll review a little bit about the newborns who are born to women who have either been using substances or have been prescribed medications throughout their pregnancy. Talk a little bit about resources in the Virginia and specifically Richmond area, and also a general discussion about CPS mandated reporting laws and what that process looks like postpartum. So our OB Motivate program, we are evidence-based, person-centered, recovery-oriented program. We are trauma-informed, and we work with a multidisciplinary team approach. We have physicians, we have nurse practitioners, registered nurses, social work. We have psychology doctoral students providing counseling. We work with other organizations providing care for people with intimate partner violence histories. We believe that in order to serve our population, we need to provide them with these resources, and not everybody needs the same thing. So we like to have our multidisciplinary team available for whatever these women need in their life to help support them. We also do a lot of training. So we have medical students, but also residents and interns, people getting addiction fellowships, social work interns. We want to kind of train the next generation of providers to combat some of the stigma that surrounds addiction care, especially with this population, so that wherever they go on in their careers, they have this basis of knowledge and care and compassionate care to take with them. So just to understand the scope of the issue, from 2010 to 2017, the rate of women with a diagnosed opiate-related disease at the time of delivery went up 131%. And those numbers are actually even higher if we look at the time period during COVID, where use and overdoses kind of exploded during that time. So while the scope of the problem is vast, pregnancy is a really good time to engage with patients and have some positive change. People can have some increased motivation to enter treatment and either get started outpatient or even residential treatment during that time. They're really focused on their own health, but also the health of their families and their baby, and kind of looking for a different future for themselves and their families. So it's a really good time to intervene and help people. Just a very brief conversation about what addiction is. So addiction is a chronic disease of the brain. So just like other chronic conditions, they don't disappear when a person becomes pregnant. If a person has had chronic asthma since they were a child, if they become pregnant, that asthma does not just disappear and go away. It's something that needs to be treated and managed during their pregnancy. It's the same with addiction. When a person has an addiction and they become pregnant, that addiction does not just disappear magically. It's something that needs to be treated and managed. And addiction is a treatable chronic condition. And a lot of the research shows that some of the risk factors for addiction are actually genetic. It is not a moral failing. It is not indicative of a person's, moral standards. It is a chronic condition that has a lot of basis in genetics, and it is treatable. So just some of the neurobiology of addiction and how it can kind of rewire a person's brain. They take a substance, they get this big dopamine surge. It feels really good. They're really happy. That goes away. They take the substance again, looking for that dopamine surge, and they get a little less dopamine. And that cycle continues, and it kind of rewires the brain. You have this memory of this wonderful dopamine surge feeling, and you're kind of searching for that feeling over and over again. So that's how the brain can change through addiction. Just because a person uses substances does not mean that they have a use disorder. Use is different from misuse. So we have the diagnostic criteria from the DSM. It's like 11 checkpoints. And during their first appointment with us, we go through that checklist with them. It's questions such as, continuing to use a substance despite negative consequences. Is it interfering with work and daily life? Things like that, to determine whether or not this person has a use disorder. And then based on those answers, you can also be classified as a mild disorder, moderate, or severe. So our model, we are looking at harm reduction, and I'm going to talk a little bit about what that means. A big part of what we focus on with our education of our other professionals is on person-centered language. Language matters, and it can really impact how a patient feels and how they feel like they're being treated. So instead of saying, we are treating addicts, or the person is a junkie, really negative connotations, we always refer to our patients as a person with a substance use disorder. We're putting that person as the center and not their use disorder as the center. Another thing that we always like to point out about words mattering, a baby cannot be born with an addiction. An addiction is a behavioral disorder. It is the action of continuing to do something despite negative consequences. That's a lot of cognition that a baby does not have. So a baby can be born with signs of withdrawal. They can be born with a dependency to a medication, but they cannot be born with an addiction. A big part of harm reduction is reducing negative consequences from someone's use. So we always advise people, whether they're using a prescribed opiate medication like methadone or buprenorphine, or if they are continuing to use illicit opiates, always telling them to not use benzodiazepines like Xanax or Ativan and alcohol. All those medications are depressants. So we don't want to add a depressant on top of a depressant, and that can impact a person's ability to breathe and their heart to pump blood and oxygen throughout their body. We also educate them on needle exchanges in our area. We do actually get a lot of patients from outside of the Richmond area. We have patients from South Boston, Mecklenburg, all over the state. So I'll try to find places in their areas where they can have needle exchanges or connect them with the ones in Richmond. There's a lot of hepatitis C that's going around, whether that's from sharing needles or sharing straws and snorting devices. So we really want to help a person if they are using and to use safely. We always give them the Never Use Alone hotline where they can call before they use, give that person their address so that there's somebody on the other line. So if they do have an overdose, somebody can call 911 for them and they don't pass away from an overdose. We give all of our patients Narcan prescriptions with infinite refills, however many they need. Some of our patients have actually called us needing extra refills because they've given the Narcan to neighbors or they've helped somebody on the street. And it really empowers them to help people in their community and also have it around for themselves if they need it as well. We provide all of our patients with lock boxes. Not only does it keep the medication safe from children, it also keeps it safe from being stolen or lost. Before we started having the lock boxes, we were asking patients, like, where are you keeping your medication? And a lot of people were like keeping it in their purse, and they'd have like, some of the Suboxone in their purse and then some of it in their nightstand and some of it here, some of it there. And it becomes really easy to lose or to lose track of. And because it is a controlled substance, if you lose it, it's very difficult to get a prescription filled early. So it's really good to keep your medication safe, not only from children, but also just from losing it in general. SAMHSA has a really good free product, the clinical guidance for treating pregnant and parenting women. You can get it on their website, and it talks about the best evidence-based research for treatment for this population. Buprenorphine, which is the main ingredient of Suboxone or Subutex, and methadone are wonderful, safe medications that can be taken during pregnancy and also in the postpartum period while breastfeeding. And these are wonderful, effective medications for treating opiate use disorder. A supervised withdrawal, even if done in a hospital setting, is not recommended during pregnancy. Withdrawal, either from heroin or fentanyl, or a withdrawal from methadone or Suboxone, can put a lot of stress on a woman's body. So it's a lot of stress on her while she's pregnant, and it's also a lot of stress on the developing fetus as well. So that's never what's recommended. Obviously, if that's what a woman wants to do, she can go into the hospital and, have her symptoms managed, and that's her decision, but it's never what we recommend. But we always recommend starting on either methadone or Suboxone. And if they're already stable on methadone or Suboxone, to just maintain that stability throughout their pregnancy and throughout the first year postpartum as well. Looking at maternal deaths, this chart is showing that maternal deaths really spike in the postpartum period. Women are really great about going to their prenatal visits, but then once the baby is there, the visit frequency drops off significantly just because life is so busy. You have the baby's appointments and now you're parenting, so life can get really complicated. So that's why we do a lot of focus on the postpartum period, whether that's with health visits, mental health visits, social work visits, really keeping people engaged in treatment. And, you know, some of these deaths are overdose deaths, suicides, but then also cardiovascular diseases and other complications that can arise from pregnancy. So while people are pregnant, we focus a lot about that postpartum period. We talk to them about pain management. We always connect them during their pregnancy with an anesthesiologist to talk about pain management, not only during the delivery, but also postpartum. So if a woman has an opiate use disorder and she has had, let's say, a C-section, she just still deserves to have that pain managed. So if she is prescribed an opiate in the postpartum period, we always recommend, if they don't feel safe managing that medication themselves, having like a trusted friend or family member with their own lockbox manage that medication for them. We don't want them to feel unsafe, but we also don't want them to suffer needlessly. We talk about birth control a lot. We are an OBGYN clinic. We have all of the options available to people, always recommending long-term options like depot shots, Nexplanon, or an IUD, allowing women to have more space and time in between pregnancies in order to let their bodies heal is really recommended. We don't want them to have like a short interval pregnancy because that can increase the risk of health conditions going forward. We talk a lot about postpartum mood and anxiety disorders. People with a substance use disorder have higher rates of PMADs, so we talk a lot about that and try to connect them with counselors while they're pregnant in order to have that safe person that they have a rapport with. So in the postpartum period, they have that extra support person available. We plan for CPS. I'll talk a little bit more later on about the mandated reporting processes in Virginia. And then, as I mentioned earlier, we always recommend continuing their medications for a year postpartum. That first year postpartum has a lot of hormonal changes, sleep disruptions, just the challenges of being a parent. And if you have a medication that's working for you and that's managing your opiate use disorder, we never want to disrupt that management. So we always recommend at least 1 year postpartum continuing that medication that's working for them. Of course, it's their medication, and if they want to discontinue that sooner, we will support them in that process. So for newborns that have been exposed to opiates, whether that's methadone, Suboxone, or heroin or fentanyl, about 50 to 80% will experience some sort of temporary withdrawal symptoms after they're born. And those symptoms show up usually within the first 4 days to 1 week of life. And the risk factors are really dependent on that baby. So male babies, bigger babies, babies who go past 40 weeks, those babies tend to have a little bit more withdrawal symptoms than younger, smaller female babies. It's a lot of genetics is really determining whether or not a baby is going to have withdrawal symptoms. It's also not really dose dependent on like Suboxone, for instance, whether a woman's taking 8 milligrams a day or 24 milligrams a day. That's not really going to impact whether or not the baby has those withdrawal symptoms. What does impact it, though, is nicotine exposure. So if you have an opiate you're taking and you're using nicotine, whether through a vape or smoking cigarettes, the more nicotine exposure, it actually increases the rates of withdrawal symptoms. So our patients are always counseled on that so that they can make informed decisions about their health care. So for treating those withdrawal symptoms, it's NAS, which is neonatal abstinence syndrome, or NOWS, neonatal opiate withdrawal syndrome. So there's some non-medicine ways to treat those symptoms. Recommending the caregiver and the baby rooming together, staying together, feeding on demand, picking up that baby, skin-to-skin contact, low lights, warm room, not a lot of stimulation. Those are all ways that mild symptoms of withdrawal can be treated. Of course, sometimes babies have more needs than that. So some babies will be treated with like morphine and then tapered down. It really just depends on the severity of their symptoms. Some of our babies from our moms go straight home after a monitoring period, whereas others do have to get some treatment, whether that's in the nursery or the NICU. It really just depends on that baby. But in terms of long-term impacts, that's not really shown in the research. Long-term, like cognitive or other impacts isn't really shown with like the methadone and the buprenorphine exposure in the prenatal period. So some other consequences of prenatal substance exposure are legal consequences, and that really depends on what state you're in. 25 states plus DC consider prenatal substance use child abuse, and a woman can be charged for that. Several states allow civil commitment of pregnant women who are using drugs. That means they can either be put into like residential or psychiatric facilities, or at times jail if a woman cannot stop using substances during pregnancy. Luckily, we are not one of those states, because the research has shown that states that criminalize substance use during pregnancy the harshest actually have worse outcomes in terms of withdrawal symptoms for the baby, and also worse health outcomes for mom. And states that have harsher penalties for women who use substances, we're also seeing higher rates of short interval pregnancies and health conditions that are detrimental to moms. And it kind of makes sense. If a mom is pregnant and she has a substance use disorder and she's scared of going to the doctor because she's scared of disclosing her substance use or being drug tested and that being reported to authorities, she's not going to go in to get that health care. So when people are scared of engaging with healthcare, they avoid it. So you see patients not getting prenatal care and sometimes not even delivering in hospitals because they're so worried about CPS involvement or becoming incarcerated, and now they are unable to parent and take care of their children. So in Virginia, hospitals, social workers, mandated reporters are required to make a report to Child Protective Services once the baby is born, if there's been any substance use during pregnancy. And that includes medications that have been prescribed, including Suboxone and methadone, and THC as well. So even if a woman has not used any illicit substances throughout her entire pregnancy, let's say she's been stable on her Suboxone for 5 years, becomes pregnant, delivers because that baby was exposed to Suboxone or methadone, a CPS report has to be made. Just because a report is made does not mean that a case is going to be opened. The CPS workers will look at the various factors in that person's life to make sure that that home environment is safe. But just knowing that a report is going to be made, it causes a lot of fear and anxiety throughout a person's pregnancy. I had a patient recently who was so nervous about CPS and somebody taking her child away from her that she hadn't bought any baby supplies because she felt like, what's the point if CPS is just going to be involved and take my baby away? So that was a really challenging case for me. There's this wonderful ProPublica graphic where you can go on and it has a map and you can kind of click state by state to see their different laws around this, and it changes frequently. And with all the personhood laws that are constantly changing, how they treat drug use during pregnancy is also changing pretty rapidly as well. Of course, we already discussed withdrawal symptoms, and then a lot of the women that I work with can have unmet social needs, so housing or food instability, unmet medical needs. Luckily in Virginia, pregnant women are eligible for Medicaid. So healthcare needs are being met. And in Virginia also, you can have Medicaid for a whole year postpartum. Other states, it was only 2 months postpartum. And if you look at the data and you see how dangerous that first year postpartum can be for women, you want them engaged in medical care. So a lot of states are changing that to be a full 12 months postpartum for the Medicaid medical care. A lot of our patients have trauma histories and again, higher risks of PMADs. So as a social worker, I think a lot about Maslow's hierarchy of needs. So if a person's basic needs, basic safety needs like food, water, shelter are not being met, it is really hard to focus on your psychological needs and your substance use disorder when you don't know if you're going to eat today. So my job is assessing for those social needs and referring to services that may be able to help. In our Richmond area, we luckily have a lot of great community programs that are free for people to engage with. Healthy Families, Family Lifeline. Project Empower is a VCU organization that specializes in helping people with intimate partner violence and trauma histories, and we partner with them a lot. I always discuss withdrawal symptoms with patients, hospital policies regarding length of stay. So when the baby is born, the average length of stay is at least 96 hours. So there's a 4-day observation period just to make sure that baby isn't going to have those withdrawal symptoms, because you don't want the baby to go home and then have these symptoms and then maybe not make it back into the hospital for some comfort meds. And then with the possible boarding, so at VCU, if there's space available, if mom has been discharged already, but baby hasn't, and the baby isn't in the NICU or needing like a higher level of care, they try to keep the baby and the mom or caregiver together. So that caregiver is learning the baby's cues and learning how to care for that baby with their withdrawal symptoms. And then of course, I always discuss the CPS reporting laws in Virginia with patients. I don't want them to be surprised. I don't want them to deliver and then all of a sudden CPS is popping into their room and they had no idea that was going to happen. So I talk about it early in the pregnancy and try to answer as many of their questions as I can.
Hey, Kalie, we have
Yes.
a great question from Susan. And speaking of reporting, I think it was in reference to your slide 2 slides ago, but she asked, is it the hospital staff who make this report? Would a provider also report once notified that patient delivered if they were aware that substances were used during the pregnancy?
Thank you. Yes. So at VCU, we have a social worker on the postpartum floor inside the hospital, and she's the one who makes the reports for us. So because we are in a hospital system where we have like outpatient and inpatient, we work really closely together so that only one person is needing to make that report. For the substance exposed infant. Also, it's better if our inpatient social worker does that because they have more information about the baby. So we're treating the women like we don't have access to the healthcare information for the baby. So the social worker for us in the hospital is reporting to CPS if the baby's having any withdrawal symptoms and also the results of the baby's drug screen. Because while a mother who delivers can decide whether or not she has a drug screen, she can say yes or no. She cannot say no for the baby being drug screened in Virginia. So if the hospital deems it appropriate for that baby's medical care to be drug screened, those results will be provided to CPS by our inpatient social worker. In general, in hospital systems, so that people kind of know who's making the reports, it's generally on the social worker to make that report, even though we're all mandated reporters, so anybody would be able to. Thank you for that. So I complete a plan of safe care, which is a document that was created by the Department of Social Services, kind of outlining all the care that a mother is receiving, who's her doctor? Has she identified a pediatrician? Is she getting any treatment for her substance use disorder, whether medication or counseling? Discussing the perinatal mood and anxiety disorders, just kind of educating people on the risk factors and also some coping skills. Our clinic, we have some grant funding and we do kind of annual donation request so that we can provide our lock boxes. We also give little gifts around the holidays, diapers, a little baby gift, like a little candle or lotion for mom, just to show them how much we appreciate them doing all this hard work and trusting us with their healthcare needs. Because again, because of the mandated reporting process, there can be a lot of mistrust with healthcare professionals. So we like to make people feel at ease with coming to us with their healthcare need. We also try to stock like diapers and wipes, snacks for patients. Our appointments are generally really long, so we want them to be comfortable during their appointments. We have belly bands and compression stockings, just little things that we can do to make them more comfortable throughout their pregnancies. I also do monthly phone calls with women who are incarcerated at Henrico County Jail. Our two doctors, Dr. Martin and Dr. Tyson, go to the jail every other week to provide prenatal care to the pregnant women there. And so part of that is me calling, doing some assessments, seeing if they need any referrals for once they're released, and also making sure that they've thought through any child care plans that they need if they're going to remain incarcerated after their delivery. We also do doula referrals. So Virginia Medicaid has started providing funding for doulas. So these are two great organizations in our area that I refer to, Urban Baby Beginnings and Birth in Color. They do a lot of work in our communities, and I know that they're spreading out to some other communities in Virginia as well. And doulas, of course, like decrease rates of C-sections, length of labor, and just kind of increase education and positive birth experiences.
Kalie, we have a few other questions. I believe you have said this, and I'm pretty sure that in Virginia, it is state law that the baby is drug tested, but just wanted to clarify. You said the mother has the choice, but the baby does not?
Yeah, the baby, they don't have the choice to decline it for the baby.
Okay.
Not all babies are drug tested. It's kind of at the discretion of the providing team. But a caregiver is not able to decline that on behalf of the baby, no.
Okay, thank you. And then Janine has asked, she asked if someone could contact about the calls with incarcerated women. She's in Goochland near the women's prison and doing early intervention. We'd love to connect with parents experiencing this.
Absolutely. So we work with an organization called the Virginia Doula Prison Project, and I think they're actually going to be a speaker for y'all in a few weeks. I saw them on your calendar.
Yes.
So they form relationships with the jails because every jail is really independently run. So you have to get permission from the sheriff at that jail in order to be able to engage with them. So the Virginia Doula Prison Project, I hope I'm getting that right, they go into Henrico Jail and actually do a weekly prenatal yoga visits with doulas. And so they have their prenatal yoga, and then they also have the doulas there to provide education about birth and birth plans. And then because they have permission from the jail, when the women go into labor, those doulas can be present at that delivery as well. And they also help facilitate a separation visit with the caregiver, the baby, and the incarcerated mother. So they have a 2 to 3 hour visit where they can all get together and talk about the care for that baby before the mother has to go back to be incarcerated. And they, this organization is also helping facilitate some women pump breast milk at the jails, and then they collect it once a week and ship it on dry ice to that baby and the caregiver. Again, it's very jail dependent. So they've tried to get in certain jails and been declined. And then they also, obviously funding is an issue as well. So they can't do as much as I'm sure they would like to. But I think they have just got accepted to go to Richmond jail. So it's really, it's growing, but it's not everywhere. But I'm sure that they would love to talk to you about your local jail. And it helps that we have a coordinator um, in Henrico Jail who's really supportive. So she's a captain. She's really supportive of this work. She helps facilitate the phone calls. She calls all the pregnant women down and then calls me at our agreed upon time and helps facilitate that as well. Because our doctors are providing the prenatal care, we have just like a really good relationship with them. So unfortunately, they're also independent, that each jail is going to decide what they allow, but I'm sure that they'd love to talk to you about that. For treatment options, there are a lot of barriers for this population getting treatment. Again, we're so lucky in Richmond to have wonderful organizations that we work with. So a big barrier for women entering residential treatment is who's going to take care of their other children and be that caregiver. We have RBHA North in Richmond, Virginia, where women can bring children up to age 11 with them into the residential program, and they have like caregivers there, and then they also help bring the children to and from school every day if they're school-age children. Women can go while they're pregnant, and then they can go immediately postpartum with their newborns as well to this drug residential program. There's also one in Hampton, Virginia called Southeastern Family Project. They are a little stricter. I think they only allow up to 1 year old. I could be wrong on that, but it's just when you call most residential drug treatment facilities, some of them will even decline to have a woman who is pregnant and close to delivery because they don't want to deal with some of that risk. So even women who are saying, I want help, if they are in a more rural area, there may not be many treatment options for them. Recovery houses are wonderful for people who need a little extra support while they're in recovery before living on their own again. Most, again, do not allow children. So it's a huge barrier for mothers. In our area, the McShin Foundation just opened a women and children's home, recovery home. And then Henrico County is trying to get grants from the opiate abatement money so that they can either open their own home or kind of help provide some financial support to women and their families, because housing is such an acute issue right now in our area and in all areas. So it can be really hard for women to find somewhere safe and a safe neighborhood for them and their families. There's also PHP and IOP programs. So those are, a PHP is a partial hospitalization program. So you go to group counseling for 5 hours a day, 5 days a week, or the IOP, which is 3 hours a day, 3 days a week. So it's more intensive counseling while still remaining in your home and in your community. That can be really hard to work and juggle childcare with those. So again, these are just kind of some obstacles that we have to think through with our patients if these are the options that they want to go with. And then, of course, we have our program, which is outpatient, and we offer behavioral health counselors, again, free to women, social work consults, and then I host a monthly women's in recovery group as well. So we talked about some of the barriers to treatment, with childcare, but then there's also a lot of that judgment and shame. Women we see frequently won't come to us until a little later in their pregnancy because maybe they've been going to their normal OBGYN and getting normal prenatal care, but they just haven't felt safe enough to disclose either that they're using illicit substances or that they're taking Suboxone or methadone, and they just don't feel comfortable sharing that. Some of that is because of the fear of CPS and the involvement of the courts or jails, and some of it is just wanting to avoid that judgment and shame and guilt. A lot of our patients who are continuing to use illicit substances have a lot of guilt themselves, and they don't need any external guilt being added to it. So until they find people that they're comfortable sharing with, they can just avoid treatment altogether. Transportation is a big barrier. We do have the bus system in Richmond, which is free, but it doesn't go everywhere, and it doesn't go really into the counties or communities. Medicaid does provide transportation, but if anybody has dealt with Medicaid transportation, you know, it is not always reliable. Sometimes it's really late, sometimes it's really early, and sometimes it doesn't come at all. So missing those appointments is a big struggle. Insurance, of course, luckily we have Medicaid, but with the re-enrollment process that happened over the past year, you know, people move a lot. So if Medicaid doesn't have your updated home address, or you are homeless and do not have a permanent address, it can be really hard to make sure you're answering all those letters for Medicaid to make sure you aren't missing that re-enrollment process. We did have a couple people miss, but we were able to get them back up and running pretty swiftly. And then, of course, post-incarceration. When a woman is incarcerated, if she's on Medicaid, her regular Medicaid is turned off and it goes to jail Medicaid. And ideally, the process to re-enroll in Medicaid starts right before you're released from jail, but that doesn't always happen. So sometimes there's a gap where we can still see patients, but sometimes they have to pay for their medications out of pocket, which not everybody is able to do. And then also, if you don't have a photo ID, some pharmacies won't let you pick up medications if you don't have a photo ID, or if women are trying to go to methadone clinics, you need some sort of ID in order to enroll. So sometimes people are ready for help, and then we have all of these social determinants factors that we need to get through before we're able to even get them started in treatment. So we've already talked a little bit about the CPS process. So in Virginia, we don't have to report during pregnancy. We just, a report has to be made postpartum because of substance exposure. And again, methadone and Suboxone are considered substances that need to be reported on. So CPS will screen the case. If it's screened in, a CPS worker will come and visit the patient in the hospital, interview the parents or caregivers, require drug screening, sometimes perform a home visit just to make sure the home is safe and appropriate. And all the adults in the house generally would have to take a drug screen to make sure that if there is some use, that they are engaging in a treatment program of some sort, even you know, the male caregivers as well, not just the woman who delivered the baby. Sometimes involved, which can include sight and sound, meaning there needs to be another adult present at all times who can see and hear the child and help care for that child. Sometimes a safety plan would include treatment for the substance use disorder, whether you know, residential or outpatient or counseling. And sometimes the baby is removed from the home. They always try to look for family caregivers. So uncles, aunts, grandmothers, sisters, things like that, and try to avoid having to place a baby into foster care. And because CPS is so region dependent, it can look different based on where the mother lives. So if a mother lives in Richmond, then we would call Richmond CPS. If they live in Goochland or New Kent, then you would call those area CPSs as well. And just based on the worker that you get, can kind of determine the flow that case takes. A few just important things to note. Epidurals that many women get during pregnancy contain fentanyl. Fentanyl is a medication that's used in hospitals. So a mother and a baby can test positive for fentanyl postpartum without any use having been taken during the prenatal period. So one positive test alone does not mean that a person has a substance use disorder. And we've educated people on this. And so if there are patients, you know, and we have a history of drug screenings, we can show, you know, if there's been no fentanyl use in all these drug screenings, and then we just have one for the baby postpartum, obviously that indicates that it's just from the epidural. But it's just good to know that just because somebody tests positive for fentanyl does not mean they have a substance use disorder. and I mentioned this earlier, but a person with a substance use disorder can be prescribed an opiate to manage pain. We don't want people suffering. Oops. Did that just go away? So that was actually the end. I do have some, here we go. Resources and just some references as well. Findtreatment.gov is a really good resource if people don't live in our community, to find community treatment providers in their area. And then some AA meetings, NA Smart Recovery, and then different domestic violence hotlines as well. And then my references as well.
Thank you, Kalie.
Yes.
And I'm just checking now. I don't see any questions in the Q&A. If anyone has any questions for Kalie, please feel free to share them now. You can put them in a Q&A and I'll continue to check the chat. We'll give just a few minutes for that, but I also want to just thank you again. This is such an important topic and so relevant right now with the slide deck.
Yeah, I can share that with y'all, and then you can send it out.
Perfect. Thank you. Thank you. We will also, this session is also being recorded, so we'll be posting it to our YouTube page, VNPC YouTube page, so you can check it out there as well.
And I definitely recommend going to the Virginia Prison Project webinar that y'all are hosting in a few months. Or I saw it on your calendar. It's going to be wonderful, I'm sure.
Thank you. One question is about connecting regarding the VA law on umbilical cord reporting and hospital policy. I think they're requesting if they can connect with you afterward. That's from Becca.
Yeah, let me put my email in the chat. I know that there was some legislation that was vetoed where they're trying to make it so that lawful THC use by a parent, it didn't mention prenatally, but just by a parent, would not be considered in like custody. That was not passed, but it has been brought up multiple times in the legislature. So, and I bring it up whenever I talk to anybody who will listen, that it's harmful and not helpful to have to report people for using their prescribed medications. So hopefully we will be closer to reducing that barrier soon, but it didn't pass this legislative term.
Well, thank you, Kalie, for joining us today. I don't see any more questions. Well, let me check. Says our local jail doesn't allow any medication during withdrawal for pregnant women. Is there a good resource to advocate to get them to change this?
So my understanding is that in Virginia, because pregnancy is I hate this, but a disability with like the ADA, that pregnant women have to be provided their methadone or Suboxone. Of course, as soon as they deliver and return to the jails, a lot of the jails aren't supportive of that, and immediately that woman is now withdrawing in the jail, freshly postpartum. So it's my understanding that the jails do have to provide medication during pregnancy because the risk to the fetus is so great for withdrawing. I'd love to know which jail that is. If you could email me, I put my email, whoever had that question, please email me, and I would love to work with you to talk to that sheriff. Because I think that everybody who goes to jail, man or woman, should have access to MOUD, but at least the pregnant women, that's a first step.
Any other questions? Okay. Well, I don't see any right now, but Kalie did share her email, and it sounds like she'd be okay if you contacted her afterwards if you have a specific situation or something about your specific hospital or locality and would like to chat with her. And her recording of this webinar will be on the YouTube page as well. So thank you all for joining us today. We really appreciate it, and we hope this was helpful. Look out for our next webinar, which will be in April. It will be off of our normal cadence of the third Tuesdays. It'll be actually on April 24th instead. So please make note of that. Any other announcements or anything, Lauren?
I think that's it. Thank you.
All right.
Thank
Thank
you for
you
having
all.
me.
Thank you.